Hello and a very good evening to my lecturer and my fellow friends. Today our group will present about transplant part 2. So I will introduce myself, which is I am Ahmad Ashraf, the number 2 person. Okay, let's go to the slide. Okay, what is graft versus host disease? It is a disease that is potentially severe risk of disease that come from allogeneic stem cells transplantation and the reduced intensity allogeneic stem cells transplantation. The disease is probably occurs during when the patient receives the stem cell from a donor, donated umbilical cord blood, and allogeneic stem cell transplantation. Next is pathophysiology of GVHD. So when the acute GVHD can be summarized as 3 steps which of the interaction within the innate and adaptive immunity, which is then innate and adaptive immunity we learn from our basic immunity. So the first step is tissue damage to the recipient by the radiation or chemotherapy of the pre-transplant conditioning regimen. And then the second step is donor T cell activation and clonal expansion. And then the third step is cellular inflammatory factors. So next slide is the graph about the what we call the pathophysiology of the GVHD. So we can see the conditioning is the first step, and then it goes through the second step, which is the donor T cell activation, and then the third step is cellular inflammatory factors, which I listed here for better sight. Then next is this is the explanation of the pathophysiology, but you can read it by your own. That's all from me. I will pass the presentation to my friend, which is Nabila. Thank you.
Thank you, Ashraf. So I will be presenting about laboratory tests for transplantation. So these are the laboratory tests. We have ABO blood typing, HLA typing, lymphocytotoxicity test, mixed leukocyte reaction, cross-matching, and serology screening. So the first laboratory test is ABO blood typing, which is also known as blood grouping. So this test is to identify the blood group of the donor and the patient. In order for us to do a transplantation, we have to identify their blood group just to continue the surgery, transplant surgery. So as we can see, this is how you read the results. So this blood grouping is done by mixing the blood sample of the patient and mix it with an antigen. It has 3 antigens, which is anti-A, anti-B, and anti-D, which is rhesus factor. So for example, as you can see, for blood type O positive, the anti-A and anti-B is not agglutinated. It shows the patient is blood group O, and anti-D is agglutinated, which shows that it is rhesus positive. The next laboratory test is HLA typing. HLA stands for human leukocyte antigen, and it is also known as tissue typing or HLA matching. Okay, and HLA typing is a genetic test. Okay, this test is compulsory in transplantation. It is used to determine the tissue type of the patient and to identify which donor matches the most, so that the donor can safely donate bone marrow, cord blood, or an organ transplant. Okay, so the minimum requirement for HLA typing, the donor must match at least 6 HLA markers with the recipient, the patient. Okay, So the test is done by taking the sample from swab of the cheek or blood sample from the vein. HLA typing is not the same with blood typing. This is because blood typing is being done to identify the blood group of the donor and patient, and it is being done when a patient need only blood from the donor, and they can receive from different type of blood group. For example, for a patient group AB, they can receive a blood type from blood group A, blood group B, and blood group O. The A typing is because the patient and the donor must match both the blood typing and the HLA typing. For example, in order to receive a solid organ transplant, the patient must match both the blood group must be compatible and the HLA typing must be matches the most. So that's all from me. I will pass the presentation to Ernie.
Thank you, Nabila. So I'm Ernie. I will continue the presentation with another test, which is mixed leukocyte reaction. It is test to quantify the degree of cluster MSC compatibility between the potential donors and recipient. The lymphocyte of the donor that have been irradiated mixed with the lymphocyte of the recipient. The irradiated cells mean the cells that have been treated with the radiation, such as X-ray or other form of radioactive. It is to prevent the transfusion-associated graft versus host disease. After that, the proliferation of response T cells indicates T cell activation is observed. It occurs when there is activation. It occurs when there is difference in cluster MSC between donor and recipient cells. The T cell activation measured by uptake of thymidine into the cell DNA. The greater the cluster MSC difference between the donor and recipient cells, the more thymidine uptake will be observed. So, intense proliferation of recipient lymphocyte indicates poor prognosis of graft survival. So, this figure summarizes what I have said before, where the donor cells is mixed with the recipient cells, and the upper situation shows the recipient cell lack of cluster MSC of the donor that cause activation and proliferation of the cell and result in thymidine uptake, while another situation, recipient cells share the cluster MSC of the donor, result in no reaction, so the donor is compatible to the recipient. Another test is cross-match. This test to detect the presence of donor-specific anti-HLA antibodies in potential allograft recipient. It means recipient serum and donor lymphocyte. Early method is complement-dependent cytotoxicity test or CDC test. It is useful for detecting anti-HLA antibodies responsible for hyperacute graft rejection, but it lacks adequate sensitivity and specificity. So, another method is developed, which is more sensitive and specific, which is flow cytometry. This figure shows the process of CDC test and flow cytometry test. For CDC, complement is added. This complement will be activated if there is antigen-antibody reaction, because it is to detect the direct binding of antibody to lymphocyte. And if the complement is activated, it will result in cell lysis, so the result of cross-match will be positive. If there is no donor-specific HLA antibodies in recipient serum, so the complement will be not activated and no cell lysis, the result will be negative. Another method is flow cytometry, where the fluorescence label antibody against human IgG will be added. It will bind to the antibody that bound to the antigen, and the fluorescence will be detected by flow cytometry and the strength is measured. If the fluorescence is detected, the result will be positive. If there is no specific HLA antibodies in the recipient serum, so no antibody will bind to the fluorescence, so the fluorescence will be not detected and the result will be negative. So conclusion, the negative cross-match will indicate the compatible, while positive cross-match will indicates the non-compatible. So that's all from me. I will pass the presentation to John. Thank you.
Thank you, Annie, for the explanation just now. I will continue for my part, which is serology testing. Okay, serology testing is basically a test which is done to screen for infectious disease to prevent unintentional disease transmission to organ recipient. These tests can also be done to anticipate potential recipient infections and to treat the post-transplantation infection after we know what infections may present after the transplantation. For these types of tests, kits has been invented to use to detect antigens, antibody, or viral nucleic acid of the infections damaged disease. These are the examples of tests that is done. There's anti-HIV1, which is 1 or 2, which is done to screen for HIV1, or HIV2 antibodies. There's also anti-CMV, which is done to screen for cytomegalovirus, and anti-EBV for Epstein-Barr virus, and so on. Next, I will continue to present the ways to prolong allograft survival. One of the ways to prolong allograft survival is by using immunosuppressive therapies. This therapy is basically a drug regimen that patients take to lower their body immune system. These drugs help doctors to stop immune system from overreacting and damaging transplanted organs and tissues. The drugs will help to reduce the risk of patient rejecting the new organ, but not all transplant requires an immunosuppressive therapies. Next, this is the process of immunosuppressive therapies. Basically, these drugs can be taken either by mouth or by injection, and the dose varies for each patient. And most patients need to take multiple drugs at a time. And doctors, physical activities and healthy diet can prevent unwanted side effects, but you need to know what are the limitations to your physical activities. Not all activities can be done. Doctors and patient will work together to make sure that medication is working and right for the patient. That is all from me. Thank you. I will pass my presentation to Amira.
Okay, thank you to my friend John. So I will explain about the usage of cytotoxic drugs and anti-inflammatory agents to prolong the allograft survival. So cytotoxic drugs is the drugs that directly interfere with DNA or RNA synthesis and will affect the cell proliferation. Initially, it is used to treat cancer, but it also can be used as immunosuppressive therapeutic agents. One of the cytotoxic drugs that can be used to prolong the allograft survival is cyclophosphamide. Cyclophosphamide is an alkylating agent that interferes with the metabolism of DNA. It also inhibits the cells from entering S phase of the cell cycle and block at the G2 phase. It is one of the most powerful inhibitors of B cells, and it also can give side effects to the patient, such as bone marrow depression with severe leukopenia and anemia. Next is azathioprine. Azathioprine is a general inhibitor of cell proliferation. It also can be used to give effects to both T and B lymphocyte reactivity. Usually, the azathioprine is used with the conjunction with baseline immunosuppression such as cyclosporine. So, azathioprine will be converted into 6-mercaptopurine by the glutathione and then convert into the mercaptopurine containing nucleotides. It will interfere the DNA synthesis and polyadenylate containing RNA. One of the nucleotides that form is known as thioguanylic acid, which then convert into thioguanosine triphosphate. Thioguanosine triphosphate can be incorporated into the nucleic acids and induce the chromosome breaks, as well as affecting synthesis of the coenzyme. Next is mycophenolate mofetil. Mycophenolate mofetil is used as a replacement for azathioprine. It is an effective inhibitor of T and B lymphocytes. It is a morpholinoester of mycophenolic acid, and mycophenolic acid is a non-competitive reversible inhibitor of IMPDH. The inhibition of IMPDH will give effect to the cell growth in other cell types besides lymphocyte and have effect in the chronic rejection. Next is anti-inflammatory agent. Anti-inflammatory agent that use is corticosteroid. Example of corticosteroid is prednisolone, and methylprednisolone. The corticosteroid will downregulate the expression of several genes that code for inflammatory cytokines. It will also inhibit the expression of adhesion molecules, cause the inhibition of leukocyte migration to sites of inflammation. This will inhibit the activity of inflammatory cells. Corticosteroids also promote the release of cellular endonuclease, leading to the induction of apoptosis in the lymphocyte and eosinophil. It also reduces the phagocytosis and killing by neutrophils and macrophage, and reduce the expression of MHC class II molecules. This will inhibit the T cell activation and T cell function. That's all from us. Thank you.